good afternoon, everyone, and thank you for that introduction. And I'd like to start also by acknowledging that I'm very grateful to be speaking on the unceded territory of the Musqueam, Squamish, and the Tsleil-Waututh nations. And yeah, my title is sweat the best antidepressant? I'm not quite sure we're going to have a clear-cut answer. I'd be interested to hear. There's another time for another discussion with Dr. Puyat about that notion of individualizing and tailoring interventions. So sweat might be the best antidepressant for some, not necessarily for everyone. But we'll see if we get to an answer and where everyone sits on that. What I'm actually more interested in is the second question: is where do we go from here? If there is evidence that exercise might be an antidepressant treatment, then how do we provide that intervention for individuals? So I'm going to start by providing a bit of some context. I'm going to focus on an overview of the evidence regarding exercise and depression, and then talk a little bit more about some of the current work I've been doing, looking more at implementation issues regarding exercise and depression. And I also want to start off by acknowledging as well that the focus of these talks are on wellness, and there is a whole body of research and an interest in how does physical activity enhance mental health and well-being of everyone, irrespective of having a mental illness. There is a lot of work in that field, and it's a very important field because I think the relationship between physical activity and mental health is so vital, because mental health is both a consequence of physical activity, but also it's likely an important antecedent of physical activity participation as well. So clearly it's a bidirectional relationship. But I'm going to put that to side and really talk more about the evidence of physical activity and exercise as prevention and a treatment of mental illness, in particular depression. So of course, the broader context that we're all familiar with, that problems, mental health problems are a public health concern, that mental health problems are widespread, that perhaps in any year, nearly 1 in 5 Canadian adults personally experience some form of mental disorder. Mental health problems may be increasing, certainly more evidence, I think, in younger age groups. And of course, mental health problems can be expensive to treat, both in terms of costs for that treatment, but also the impact that it has on quality of life. And certainly this is some of the foundational work that I draw on for looking at building on the case for addressing mental health problems. When we look at the impact of mental health on health adjusted life years, so a kind of a combination of years of life lost due to premature mortality, but also reduced functioning due to disease and disability. And this report from Ontario, I think probably at the time, and probably still is, the most extensive report demonstrating that the burden of mental illness and addictions in Ontario, at least, was more than 1.5 times that of all cancers and more than 7 times that of all infectious diseases. And within that, depression carries the greatest burden. So of course we are interested in addressing poor mental health. Again, putting aside some of the social determinants of poor mental health and looking just at how we treat mental illness. We have challenges potentially with access, of how individuals can access therapy or access medication that can be more or less difficult in different places where you live in Canada. We know that the common approaches, including talking therapy, medication, they work for some people to a certain extent. But the effect sizes or the effects that evidence meta-analyses tend to demonstrate that those effects are small to moderate overall. And so they don't, of course, work for everyone. And here is just an example of one of those meta-analyses, just focusing on antidepressant medication, which is perhaps the frontline treatment for depression, looking at the comparative efficacy and acceptability of different antidepressants. And I just wanted to kind of draw kind of attention to standardized mean difference, because I'll come back to this, that when we look at the differences between treatments using medication and some kind of placebo control, again, we tend to see a small difference. between 0 to -3, 0.3 to 0.5, 0.6, a moderate. Anything higher than 0.6, 0.7 is a large effect. And so when we look at antidepressants, what we tend to see is overall this small effect that again suggests that yes, it works, but not for everyone, and the effects tend to be modest in nature. So I'll come back to that. I'm deliberately making kind of reference to that standardized mean difference. And of course, with antidepressants, with medication, there can be concerns with side effects, whether that's for young children, adolescents, regarding increased risk of suicidal ideation, whether it's the impact of medication on sexual functioning. This is just a kind of a neat study that was actually looking at an exercise intervention for depression and looking at the impact of sexual functioning in depressed adults. And of course, just looking at that graph, found that there were greater side effects, negative side effects for individuals who are taking the antidepressant or placebo. So that might be rationale enough to suggest that sweat is the best antidepressant, that it doesn't have an impact on sexual functioning. Not that exercise improves your sexual functioning, but that it doesn't carry the same side effects as medication. So kind of coming down very quickly to why the advantages of physical activity and exercise in considering it as a treatment for depression. Well, of course, we know that there are tremendous physical health benefits accrued through physical activity and exercise that you're unlikely to be, well, I can't think you can see through something like medication and talking therapy. And we have a wealth of evidence that people who are active live longer and live better, healthier lives. Potentially, interventions using physical activity exercise are cheaper than medication, cheaper than counseling. Again, there's actually very little evidence, of cost effectiveness research that demonstrates that, but it's clearly plausible when we compare an exercise program perhaps to a program of intensive psychotherapy. It's cheaper because it's something that can be self-administered to a certain extent. There are no negative side effects that we're aware of if it's done with care and caution. I think what I'm most interested in with this angle is because I do work around physical activity intervention, particularly at a population level, that physical activity is something that is far-reaching, that working with any organizations that have some kind of role to play in promoting physical activity are also in the business of mental health promotion as well. That this is a strategy that can be implemented or promoted at a national level, that if individuals are adopting, it may be having an impact on their mental health as well. But now let's look at the evidence for depression. And we can consider, when we look at mental illness and physical activity exercise, firstly, we may be very interested in a protective role at a population level. Are individuals who are more active less likely to report depression at a later point in time? And here is a review that we've done, looking at just prospective studies, typically large-scale survey studies that are assessing self-report mental health, self-report physical activity at different points in time. And we clearly showed in this fairly consistent findings that, yes, individuals who are physically active are less likely to report depression at a later point in time. Similarly, individuals who are, if we look at individuals who are declining their physical activity over time, then we see an increase in the risk of depression. I think the question about that is something that we still need to kind of do more work at in the field of physical activity and mental health from a protective role, is that, of course, there may be some questions around reverse causality. So, of course, what's causing what? Is it the inactivity that leads to depression, or is it the depression that leads to inactivity? There's also concerns with these large-scale types of studies with self-report and the bias that comes with that in terms of reporting how active one actually is, and also reporting one's own mental health status. And there's also issue of confounders again. Is it as simple as saying it's the physical activity that's protective, or are people who are physically active more educated or have a higher income or have a greater social support network. And that is really what is explaining the relationship between physical activity and reduced risk of depression. Now, most of the studies do try to control for confounders, but certainly can't rule out that possibility. I just want to flag this one study, which was really intriguing, very complicated, that actually tried to address a lot of those concerns. Another confounding factor is potentially genetics. Is there some genetic predisposition to either be physically active or to either be at a greater risk of depression? And this study was using two large data sets in the UK, looking at the biobank data set, which collects genetic information, but it's also collecting physical activity information using accelerometers, using an objective measure of physical activity. And it also has clinical diagnostic information about individuals. So within this large study, they were able to really just focus on some of those concerns that we reported or identified in our systematic review of the literature. And of course, what they found was very supportive, again, of this protective role, that there was a moderate reduction in depression risk with a standard deviation increase in physical activity measured by accelerometry. So using the best device-based assessment of physical activity, there was this significant risk reduction in risk. But there was no evidence of a bidirectional relationship that depression led to physical inactivity. And they were even able to, given the measures that they were using, come up with a kind of an estimate of the dose of physical activity, that if you could replace your inactivity with 15 minutes of vigorous physical activity or an hour of moderate to vigorous physical activity, or some combination of that there was a significant risk of depression. So here is now a kind of a tailored, almost lifestyle message that could be communicated at a population level, that we might hope to see a reduction in risk of depression. So I think that's an exciting area of work, is looking at this preventive role. There is quite a lot of evidence regarding depression, less evidence about anxiety and other mental disorders, just mainly because of lack of studies that have measured those. I'm now going to look at the case for exercise as a treatment for clinical depression. And I'm going to start off with, what we all know probably are have quite a lot of impact, high credibility, of these Cochrane Library systematic reviews that I think tend to be quite influential in informing decisions around treatments and policies. And this was the first one in 2013 that came out. And I'm just going to kind of show you, and again, you don't need to look at the details here. This is just a nice forest plot of the RCTs, randomized controlled trials at the time. And that overall, the figure here, so remember I talked about the standardized mean difference, and a small effect is about 0 to -3.4 to 6, moderate, anything higher than that is large. Well, here we see, so there's quite a few randomized controlled trials of exercise for depression. And the effect that we see is large. That there's a significant difference or improvement in the individuals receiving exercise in comparison to control. Now, as you do when you're doing systematic reviews, you do your sub-analyses, and an important one to do is to look at the strongest, most rigorous studies. And so the studies that have blinding, for example, that the testers weren't aware of which groups people were being assigned to, and so on, that there's concealment of the randomization, all of these high quality checks on ensuring the studies are as strong as possible. Now, when you look at just the strong qualities, yes, the effect goes down. So it's now a small effect, that it's still significant. Your exercise appears superior to a control condition, but the effect is small. Now, of course, that's why I brought up in that first systematic review and meta-analysis of antidepressant medication that they found overall that the effect was small. It was 0.3. And of course, this is now recognized that small effect is, while it suggests that it's weak one, I think this is a good quote that kind of highlights that, it doesn't mean that the treatment is not working or does not make any clinically relevant difference, but it neglects the fact that such an effect size is the rule rather than the exception for efficacious treatments in psychiatry. So these small effects, no matter whether we're talking about exercise, antidepressant medication, or therapy, are quite common. And even when we look at, in that first Cochrane review, these are studies at the time were the only studies that directly compared exercise with antidepressant medication. They found actually no effect, that there was no difference between exercise and antidepressants in the treatment of depression. Now, this has received some criticism because it's interesting in this review that the conclusion is that the available evidence suggests that exercise is no more effective than either psychological or pharmacological treatments. And so again, I use this review, and many people do use this review as in our teaching, talking about evidence-based medicine to students, to talk about there is somewhat still a lot of opportunity for subjective interpretation, even when we're dealing with these systematic reviews, because I think probably a more appropriate intervention is that the available evidence suggests that exercise is as effective as psychological or pharmacological treatments. But again, we're not necessarily, or I'm not necessarily trying to make the case that exercise is better than other treatment approaches, rather that the exercise appears to have similar effects. This is just, again, another systematic review, meta-analysis. And this is, in this study, they were actually looking much more at studies that had adult patients in mental health services. So again, one of the criticisms of some of this, or not criticisms, or a question that you might have about this evidence is, well, how, the people who participate in these exercise interventions, how similar are they to the types of people I might see in clinical practice? And so this is a review of those studies that best reflects that. Individuals who are in mental health services, and we see and hear again a kind of a large effect that exercise appears to be effective in comparison to a control condition. And so that kind of leads us to where we are at in Canada and the CANMAT 2016 clinical guidelines for the management of adults with major depressive disorder. I think something that we can or should celebrate in Canada is that we're one of the first countries, if not one of the only ones, that explicitly acknowledges exercise as a first-line treatment for mild to moderate depression, and lowers the tone somewhat for moderate to severe moderate depression. But certainly based on that meta-analytic evidence, it certainly had to acknowledge exercise seemed to be another evidence-based option for patients and treatment providers to consider. So again, when I go back to that question is sweat the best antidepressant? Well, different ways to think about that. I'd like to think of it more as it's another option that again, based on patient preference, based on treatment providers that may be available, it should be another option that individuals can consider. And again, this is the last, I'm sure this is the last of these charts that I'll be showing you, but this is just a study that we literally published and was available last week, where we compared what happens when we add exercise to standard treatment, whether that is medication and whether that is talking therapy. And again, we found a moderate effect that adding exercise actually was more effective than standard treatment alone. Now, it's interesting that was largely driven by the medication studies, that when you added exercise to medication, that was more, the effect was quite modest to moderate to strong in comparison to adding exercise to therapy. And I think there are two ways that we interpret that. One is that in these studies, the therapy condition was relatively weak, methodologically, particularly in terms of how the dose was described, but also it's maybe tied into mechanisms. And that's something that I'm interested in at the moment, is looking at mechanisms through which physical activity might be working and how they may be complementary to the mechanisms through which other treatment approaches are operating. And so potentially, I think the mechanisms for how physical activity work may be more in common to how therapy might work. And so we see a little bit of a washout when you add the two together, but medication and exercise may be operating through different but complementary mechanisms. And so we see a larger effect. That is purely speculative. Some of the other studies that we've done recently is just been trying to tack ourselves onto other antidepressant trials, which aren't about physical activity at all, but where we've convinced the trialists, or they just happen to be measuring physical activity in some way or another. And this was a study that I knew Roger McIntyre, and some of you may know, in Toronto, and he was doing a study looking at a medication trial, but he was looking at a cognitive measure. I think he was really just testing to see whether this cognitive tool was better at assessing changes in cognitive functioning as a result of a response to antidepressants. So again, we were less interested in what the intervention was, but we managed to convince Roger to add a physical activity self-report measure at 3 time points, at baseline, at week 4 and week 8. And again, we saw a nice kind of finding here when we compared the responders, so where the responders was for whom there was a 50% reduction in their depression scores. We saw a significant increase in physical activity at the midpoint that was sustained at the end of the trial in comparison to those who did not respond. So again, either people may have felt, because it was self-report, may have felt they were getting better, that they were more active, or maybe they were actually increasing their physical activity. And we're kind of intrigued about how that change in physical activity is also supporting the antidepressant response in some way. We've also done some work interested in RTMS as well, which is another treatment approach to depression, which is an interesting one, obviously for cognitive functioning, and that there is evidence that physical activity impacts cognitive functioning as well. So there might be some synergy here as well in terms of the types of mechanisms that are operating. And I've been, had a lot of fun working with Fidel Vila-Rodriguez, who does this work here at UBC. And again, we had the opportunity, using measures that he was collecting, using Actical monitors. So these are device-based measures. So getting away from self-report to actually looking at, an objective measure of physical activity, if you like. And again, we saw when we looked at the responders versus the non-responders, a significant increase in physical activity over the time of the intervention, which again suggested that as people were getting better, they were getting more physically active. And again, my interest there is that how that increase in physical activity is also helping with the antidepressant response. Okay, so now I'm going to change track to look at this question. So where are the practical and scalable exercise interventions that can be embedded in routine practice? So again, we've got this fantastic body of evidence that RCTs, that exercise works. We have these CANMAT clinical guidelines that recommend exercise as frontline treatment. But if you were if you're someone with depression and thinking about exercise as a treatment, what would you do? Where would you go? If you're a psychiatrist or a mental health professional and you had a patient who was interested in exercise, what would you do? And so that's what I'm kind of interested in, is that kind of practice gap. And because there is one challenge that I'm going to talk a little bit about, that I keep on using the terms, probably in this talk, interchangeably, exercise and physical activity. And that's a no-no. But I'll tell you now how they're distinct. So physical activity is any movement that incurs energy expenditure. Now, a type of physical activity is exercise, and exercise is something that is typically structured and supervised with a purpose, a goal of getting fit. Now, at a population level and from a behavioral medicine approach, we're often interested in promoting physical activity because that is something that is easier for many of us to do, that we can integrate physical activity into the day, that we can walk to the bus in the morning, we can go for a walk at lunchtime, around the workplace, and then we can go for a walk after dinner, and we can accumulate physical activity into our day. Now, exercise has a lot of different connotations. It implies a kind of some time that will be needed, some structure that you'll need to go maybe to a gym, that you'll need to be habitual in kind of setting out a time where you're going to go for that jog after work. And so a lot of the interventions, or if not, sorry, all of the evidence that I've referred to is really looking at exercise and looking at this structured, supervised type of activity. This is an intervention, again, quite a well-publicized one, that took that different approach of looking at how do we help individuals with depression increase their physical activity throughout the day. And of course, what they found, and it was blared in the headlines in the UK, was that exercise doesn't help depression, study concludes. And of course, this is how you get this kind of a study gets published, and then how it gets interpreted and spun in the media a lot can go on there. But of course, as I've just mentioned, this intervention wasn't about exercise at all. It was about physical activity. Of course, the study author, though, didn't help kind of things in terms of that press release that acknowledges that many patients suffering from depression would prefer not to have to take traditional antidepressant medication, preferring to instead to consider alternative non-drug-based forms of therapy. Exercise and activity appear to offer promise as one such treatment, but this carefully designed research study has shown that exercise does not appear to be effective in treating depression. So, of course, this is also another study that I use with students regarding evidence-based medicine. There are a lot of problems with the study in terms of standard care in the UK. It often uses physical activity and exercise as a low-intensity behavioral intervention that may have been recommended to the control group. There was actually no difference in the groups in physical activity. So the intervention itself, the behavioral intervention, was ineffective in actually changing physical activity. So jumping the gun to suggest that physical activity was ineffective is not actually supported, firstly, by the lack of implementation. And again, that may have been because the intervention was delivered by non-specialists with minimal training and was based on this very relatively basic physical activity counseling model, talking to individuals about setting goals, looking at barriers to physical activity, and developing plans to overcome those. Suffice to say that based on some of those meta-analyses, though, this is the challenge, is that it does appear that interventions do need to be structured and supervised, and that they need to be delivered by healthcare professionals with specific training in exercise prescription. And so that's, I think, the challenge for us in the field of exercise and depression, so to speak, is we do need to think maybe about how do we provide these types of interventions more often, and perhaps not be reliant on more lifestyle physical activity interventions. But of course, these interventions have some resource implications. And firstly, we need to have that interdisciplinary collaboration and mental health professionals who perceive exercise as a credible treatment. They know how to access potentially exercise resources and professionals in the community. And they also have the skills and confidence to talk about exercise as a treatment for individuals with depression. And at the other end of that tunnel, we need exercise professionals who have mental health literacy, who have the skills, again, confidence to work with individuals with depression. They know they have the capacity and skills to reach out to mental health professionals, to develop referral opportunities, and they can make their services accessible. So I'm just going to talk about two projects that we've done along those lines. So firstly, working at the mental health professionals, Krista Glowacki, Dr. Glowacki now, I should call her. She was a former PhD student. Her project was developing an evidence-informed exercise and depression toolkit that was grounded in the evidence, that involved several scoping reviews, an expert panel, and then this creation of a toolkit that is really targeting mental health professionals to exactly that, help them develop the skills and confidence to discuss exercise as a treatment option for individuals with depression. And that toolkit is freely available at our, we spent a lot of time thinking about this, the exerciseanddepression.ca website, if you're interested in that resource. More recently, we've looked at the other end of that kind of tunnel and looked at the kinesiologist or the exercise professional. And again, considering how they can be part of the mental health care team and mental health and become, in a way, mental health professionals themselves. And so we've been working with CSEP, which is the Canadian Society of Exercise Physiology, who are perhaps the largest and certainly the most credible certifying body in Canada of exercise professionals. We've teamed with them to develop an 8-hour interactive textbook for exercise practitioners, which is really mental health literacy and that training, but also with some material looking at how would you develop and tailor an exercise program for someone with depression. We've started off with this 8-hour CPD training interactive textbook, and we're now at the moment in the process developing an extended program which leads to certification for exercise professionals in exercise and depression. And again, we're working on that basis that again, mental health professionals are going to be more, hopefully more engaged with working with someone that they know that has some training and oversight, supervision, in exercise and depression. And at the same time, this becomes an opportunity for exercise professionals with this type of training to reach out to mental health professionals to make those links. And what I haven't really spoken to you about at all is some of the work we're doing in the middle, that we're developing expertise in mental health professionals and exercise professionals. We're also working on several types of referral systems that can actually connect the two. And I'll save that for another day, or if there are any questions. But is sweat the best antidepressant? I think yes, at the population level, most definitely so. That in comparison to other therapeutic approaches, this is one that can be promoted at scale, and that we can consider physical activity as a mental health promotion strategy. I think at the service level, I would say it's a little bit more nuanced. Again, I think exercise is another option, and it's going to appeal to some. It's not something that I'm suggesting everyone should try, but I like the idea, and I've always tried to play around with it and thought about it, is that kind of treatment aptitude interaction is, I think our type of where we're at with the exercise and depression work is perhaps more trying to figure out who is going to most respond to exercise. And again, can we tailor the treatment provision in a way that exercise gets, we provide exercise as an opportunity for people who are really going to respond best to it. I think we need to do, the assertive knowledge exchange. That is part of, the reason for wanting to speak today is always getting that message out about exercise and depression. But again, it is trying to kind of get out of silos and talk to other professionals in different mental health fields, because of course, I think interdisciplinary collaboration is ultimately going to be essential to make exercise a more common treatment option in Canada. And certainly pragmatic research designs are needed. Again, I haven't spoken too much at all about the potential limitations of, there are limitations in all research, but the limitations of the exercise and depression research. One of the problems that I see is that a lot of these studies are efficacy trials. So they're showing that exercise works in the best conditions, control conditions of a randomized controlled trial. But we now need to start doing more effectiveness research of looking at how exercise works in the real world. So that's it from me, just to flag that there is a journal, Mental Health and Physical Activity, if you're interested in research on this particular topic. It's now into its 12th year of publication, and it's another resource that you might be interested in. Thank you very much.